Hello, this is Dr. Jagadish Jamboti. I'm a consultant nephrologist at Fiona Stanley Hospital in Perth. In the next 45 minutes or so, we'll be discussing about the amazing organs that we have got, that we are endowed with. Those are the kidneys, as we celebrate the World Kidney Day on the 10th of March this year. Every year, World Kidney Day is celebrated on the second Thursday of March, and it happens to be the 10th March this year. The theme for this year is to bridge the knowledge gap, to improve our health literacy about what we know about the kidneys, how they function, what are the various treatment options, etc. So let's begin. Let's begin with a very simple question: where are the kidneys located? They are located on either side of the spine. They measure about 10 to 12 centimeters in length. They're partly covered by the lower ribs posteriorly, and part of them, you can see them just below the ribs there. And each kidney has got an artery that supplies it, the renal artery that arises from the main blood vessel from the heart, that's the aorta. And then the renal vein drains the blood away from the kidneys. And what is filtered and what is the net urine that is formed at the end of the filtration and reabsorption and secretion process is drained out as urine through the ureter into the bladder, and then it is stored in the bladder before it is discharged through the urethra from time to time. The kidneys are made up of these million superfine filters. Each kidney is composed of more than a million nephrons. These are the fine filtering heads there. The filtering head is called the glomerulus, which is a bunch of fine capillaries. The renal artery comes, the afferent arteriole for each glomerulus divides into a very fine network of capillaries, so that the filtration of blood can happen across these capillaries. Once the filtrate is formed, it goes through these convoluted tubules. The proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, wherein further modification of this filtrate occurs. There is a process of reabsorption and there is a process of secretion depending on what the body needs at that point of time. For example, if you're working on a hot day in the sun, you tend to pass less urine, more concentrated urine. And that's because the kidneys perceive that the body needs to retain water, and therefore they do it very efficiently. So you pass less urine but more concentrated urine to get rid of all the waste products. As opposed to that, on a wintry day, if you drink 2 liters of water, you will rush to the toilet because there is an excess of body water that is perceived by the body, and the kidneys are directed to get rid of that extra water as quickly as possible. And that happens by passing dilute large amount urine. On an average, the kidneys, the amazing organs that they filter about 180 liters of blood over a 24-hour period. And then through the process of reabsorption and secretion, 178 liters of the blood or the filtrate is reabsorbed through these capillaries, through the peritubular capillaries back to the renal vein, and so you end up passing only about 2 liters of urine on an average per day. You can imagine how efficient filters the kidneys are, how amazing the kidneys are. They function mainly to bring about the internal balance of the body, and that's called homeostasis. They maintain that internal balance, and they're the main orchestrators by eliminating the waste products like the protein metabolism waste products, the acid that is built up in the body that's gotten rid of by the kidneys. The kidneys are very important in the water and mineral metabolism. We talked about the water. Similarly, for various minerals like sodium, potassium, calcium, a lot of these minerals are dependent on the proper functioning of the kidneys for their proper concentration in the blood so that the body can function normally and efficiently. One of the major sources of metabolic acid is the protein metabolism, and the kidneys get rid of that by removing the acid in the urine. And also they synthesize bicarbonate, which nullifies the action of the acid. The other thing that the kidneys are very important to deal with are with the osmolarity of the plasma. The plasma has to be of a certain fluidity, or the blood has to be fluid to a certain extent to ensure that there is a proper perfusion of the organs and tissues. If it becomes too thick, too viscous, then the perfusion suffers. And the opposite, like if there is a very dilute plasma, it's again not good because it will lead to tissue edema. So there has to be a plasma osmolarity that has to be kept in a very close range, and that is performed by the kidneys by getting rid of the extra water and taking care of the osmolarity in a very narrow range. And the kidneys are also important endocrine organs. They produce erythropoietin. Erythropoietin produced by the kidneys acts on the bone marrow to produce the red blood cells that carry the hemoglobin. So very important there. And for vitamin D synthesis, which is important, as we all know, in the bone health and in muscle contraction, nervous system excitation, muscle excitation, etc. So a lot of critical functions depend on the kidneys working properly, and therefore they contribute to the homeostasis as the main orchestrators of the internal homeostasis of our body. And no wonder when the kidneys are not functioning, when we encounter a condition called chronic kidney disease, which is a dysfunction of the kidney that occurs over months to years and is gradually progressive. It can lead to what we call as end stage kidney disease, and that is now ranked number 10 in the major killer diseases. Definitely not something that we can be proud of, but there are some things that we can do to alleviate this situation, and let's see what are the things that we can address. If you looked at the previous slide, you saw that heart disease was now ranked number 1 as a major killer, followed by stroke, and then the chronic obstructive pulmonary disease, and then followed by kidney disease number 10, just preceded by diabetes. All of these have a common theme, that there are some common conditions that predispose to these diseases. Obesity, smoking, physical inactivity. All of these could be the primary drivers for diabetes, high blood pressure in many individuals, and that can in turn lead to heart disease, ischemic heart disease, or cerebrovascular disease resulting in stroke, and in some patients it can lead to chronic kidney disease and ultimately death. So if we can address these common factors that can predispose to many major killer diseases, I think we can make a great progress in improving the health, general health of the mankind. What are the common signs and symptoms of chronic kidney disease? Let's look at what the kidneys themselves cause in terms of signs and symptoms. Like there could be reduced urine output or even an increase in the urine output. That's because the kidneys have lost the ability to concentrate the urine. You saw in the previous slide that from a filtrate, glomerular filtrate of 180 liters, you only produce 2 liters of urine. The rest of the filtrate is reabsorbed along the nephron, along the tubules. And therefore, when the kidneys are dysfunctional, there can be a concentrating defect and a person can start passing more and more urine, dilute urine. Because of the retention of salt and water, there could be edema or swelling of the face, feet. And when the filter, the nephron, the glomerulus gets damaged, the fine filter that it is, it normally holds back all the essential substances in the body, like the protein, the serum albumin, and that gets leaking when the filter is damaged. And the urine albumin shows up as froth when the toilet is flushed. Or there could be blood in the urine because the red blood cells are escaping through the glomerular filter, which is normally supposed to be tight. And then we talked about the endocrine function, and because of that, because of the lack of erythropoietin, there could be anemia. And kidneys are very important in regulating the blood pressure. Just as a heart is important as a pump, the vascular tone, the blood vessel tone is determined by the substances that are produced by the kidneys, like renin, angiotensin, and all of that. And that mediates the increase in the blood pressure. We'll come to this blood pressure and the blood pressure medications in managing chronic kidney disease in a short while. But new onset high blood pressure could be an indication that there is something amiss with the kidneys. And so at that stage, if any of these signs symptoms occur, it's prudent that you get a urine test done, you get a blood test done, you seek medical advice and proceed accordingly. We talked about the various other organs that can get affected once the internal homeostasis is disturbed if the kidneys are dysfunctional. It can have impact on almost all the organs in the body. The person may experience breathlessness because of anemia, because of fluid accumulation in the lungs. There can be arrhythmias in the heart. There can be nausea and vomiting. And in fact, many a time, the patient has undergone a plethora of investigations, endoscopies, CT scans, and all that before a blood test looking for kidney function or a urine test is performed. And that tells you that there is kidney damage. There could be muscle spasms, bone pains because of the calcium and vitamin D abnormalities, menstrual irregularities in ladies, generalized itching, and the nervous system can also be impacted by way of the person becoming more drowsy, somnolent, and sometimes in extreme cases getting seizures. So the manifestations can be protean. But you should also remember that the kidney disease could be silent until it is very, very late in the day. Like until the patient comes with very late manifestations, they may have noticed hardly any symptoms. And it may come as a shock that the patient has end-stage kidney disease that requires permanent dialysis or transplantation of kidney. A famous American physiologist, Professor Homer Smith, was also a very famous author. He wrote, "We have the kind of blood because we have the kind of kidneys we have. Only because they work the way they do has it become possible for us to have bones, muscles, glands, and brains. Our kidneys constitute the major foundation of our philosophical freedom," he said. Such amazing kidneys. Who should we be screening for chronic kidney disease? Usually, chronic kidney disease is more prevalent in people above the age of 50, with those having diabetes, high blood pressure, those who are smokers, those who are obese, or in someone who has a first degree relative with chronic kidney disease. Unfortunately, indigenous Australians and indigenous population elsewhere in the world are more prone for chronic kidney disease and other chronic diseases. So these are the ones that should be screened. If the previous year's screening for chronic kidney disease, and we will come to how we screen in a minute, if that has been normal, you go for a test every year. If it has been abnormal, seek medical help, medical advice, and probably you will need to do these tests more often. And what are the screening tests that you need for determining whether the kidneys are functioning properly or not? Firstly, the urine. Look at the urine for any albumin or blood. It could be done by a dipstick, wherein you look for any blood traces of blood, or then you send the specimen to the laboratory where they can do a urinary albumin to creatinine ratio, or look under the microscope for any red blood cells, any other abnormalities, etc. Any presence of albumin in the urine will tell you that the kidney filter is damaged. Any presence of blood in the urine will again tell you that there is a damage to the kidney filter. There are certain blood tests, and the most important of them is the measurement of serum creatinine. The muscles, they release a substance called creatine, which is converted in our body into creatinine. And this creatinine is excreted by the kidneys. And when there is kidney dysfunction, obviously the serum creatinine levels are elevated. And based on this serum creatinine measure and the age and the gender of the person, we can compute, we can calculate, or we can estimate what is the kidney function or what is the glomerular filtration rate. This is called as estimated glomerular filtration rate, or in short, eGFR. Normal eGFR is about 90 to 120 mils per minute, or roughly about 100 if you want to approximate it, 100 mils per minute for an adult, normal sized adult. And therefore, whatever the eGFR is, that could be considered in an approximate way as the percentage kidney function of your kidneys. HbA1c or glycosylated hemoglobin is important to measure every 3 months in a diabetic patient to see how the average control of diabetes has been in the preceding 3 months. And then this may lead to ultrasound examination of the kidneys or further specialized examination of the kidneys and the blood tests and all of that. That will be guided by your specialist doctor or consultant nephrologist or by your general practitioner. So based on the estimated GFR, the chronic kidney disease can be divided into 5 stages. I'm not covering acute kidney injury, which is a form of a sudden severe kidney injury that can lead to kidney failure requiring dialysis, but the chances of recovery there are also there. Therefore, a person can recover from acute kidney injury, although it is more severe and more sudden. Whereas chronic kidney disease is something that comes in more gradually over months or years and is more damaging, like a constant damage that only gets worse as the time passes. Unless we take measures to halt or prevent the progression or to retard the progression of the chronic kidney disease. So stage 1 is where the kidney function is nearly normal, but there is some other abnormality, like there is presence of blood, there is presence of protein, or there is an ultrasound imaging that shows polycystic kidneys, etc. Stage 2 is early kidney damage, and most often we tend to see as nephrologists patients referred with stage 3 kidney disease and onwards, where there is moderate to severe reduction in the kidney function or estimated GFR. Stage 5 or end stage kidney disease is where the patient requires dialysis support or would require to go and get a kidney transplant. And then we also talked about the albuminuria or the proteinuria, and if you compound that into this estimated GFR, you see that the risk of progression to end-stage kidney disease is worse as the albuminuria or the proteinuria levels increase for the same level of estimated GFR. So there are two components to the determinants of the progression of the chronic kidney disease. One is the estimated GFR by itself, and then that is compounded or multiplied by the amount of proteinuria. And this is important because we can target this. We can target the blood pressure, we can target the protein loss in the urine to reduce the risk of reaching end-stage kidney disease. And how can we do that? One is, of course, if the person is diabetic, glucose control is very important, and HbA1c or glycosylated hemoglobin between 7 to 7.5%. That would be the target blood glucose average control. Use of various medications. And in the last decade, there has been an explosion of anti-diabetic medications that have come into the practice. And we're really lucky to be in this era where we can achieve much better control of diabetes and hopefully prevent the progression of diabetic nephropathy to requiring end-stage kidney disease. Blood pressure control is very, very important. A reading of 120 by 80 millimeters mercury would be ideal for a person with chronic kidney disease. And that coupled with the urinary protein control, reduction in the urinary protein control can be achieved by these agents called as angiotensin converting enzyme inhibitors or angiotensin receptor blockers. I will touch upon that in a separate slide. So these agents have this dual action, and those have been in use in the last couple of decades. Again, something that has helped us in reducing the progression of chronic kidney disease. Of course, very important to give up smoking, address obesity issues, more physical activity, control the lipids with diet, with medications. Lifestyle is important common denominator for all of this. Food should be, we should be very cautious about the amount of salt that we eat, and in those with diabetes, the amount of glucose, sugar that we take in our diet. And also patients with chronic kidney disease should restrict the protein amount that they ingest to a moderate amount. 1 milligram per kilo weight of the person. So if the person is a 70 kg person, weighs 70 kilos, the recommended allowance of protein is 70 milligram per day. Oh, sorry, 70 gram per day, 1 gram per kilo. Adequate sleep, about 8 hours of sleep. Very important also to keep a happy disposition, because all the stress hormones that are released when we are angry, when we are dissatisfied, when we are restless, all of these stress hormones do tend to cause the blood pressure to go up, to cause the blood glucose to go up, and all of this. All this stress response is not good chronically. And to achieve a work-life balance, to make sure that you don't overwork, to make sure that you spend adequate time with your family, with your friends, and you have some time for yourself. I mentioned about the medications called angiotensin receptor blockers or angiotensin converting enzyme inhibitors. These are important armamentarium in our tool to reduce or retard the progression of chronic kidney disease. What happens when the majority of the glomeruli are destroyed, nephrons are destroyed, is the remaining ones, they tend to overwork. They tend to be acted by this renin that is produced by the kidneys, the ischemic kidneys, the dysfunctional failing kidneys, an increased amount of renin that is produced as it perceives that there is a decrease in the GFR. And what it does finally, it leads to the activation of angiotensin 2. This angiotensin 2 is a very powerful vasoconstrictor. That means it constricts the efferent arteriole. And what it does is it increases the pressure within the glomerulus, and that leads to further damage to this surviving glomerulus, leads to fibrosis, leads to worsening proteinuria, worsening blood pressure, all of this. And that can be controlled by administering medications called angiotensin converting enzyme inhibitors, the inhibitors of the angiotensin 2, that final pathway there, or angiotensin receptor blockers. So the receptors are blocked. So what happens is this vasoconstrictor effect and all the deleterious effect that this increase in the angiotensin 2 levels has brought about as a result of chronic kidney disease is reversed at least partially. And what we see in terms of clinical results is there is an improvement or a reduction in the blood pressure. There is an improvement or a reduction in the amount of protein that is lost in the urine. And by both these mechanisms, we can protect the kidneys for longer and delay the need for dialysis support or transplant. What are the special precautions that one has to take if the person has chronic kidney disease? One has to be very wary and avoid anti-inflammatory medications because they can cause an acute dysfunction of the kidney. Avoid traditional medications or herbal medications because they can also cause kidney damage. Beware of over-the-counter medications because you don't know the dose that is required or whether it is harmful potentially to the kidneys or what is the dose, etc. And even the medications that are good for the chronic or the long-term management of the chronic kidney disease, like the ACE inhibitors or the angiotensin receptor blockers that we talked about, they should be avoided if the person is acutely unwell. Like if the person is having persistent nausea, vomiting, unable to keep down fluids, blood pressure low, conditions like that, it is better to avoid ACE inhibitors or angiotensin receptor blockers. Otherwise, the person can end up with an acute or chronic kidney injury. So when you talk to your pharmacist or when you talk to your doctor, make sure that you have a list of sick day medications that you need to avoid on a day that you are sick. That's very important to prevent any acute or chronic kidney damage. And also ensure that you inform your healthcare provider, your pharmacist, your general practitioner, your physician, your specialist doctor about your chronic kidney disease status, what stage you are, what is your kidney number, or what your estimated GFR, what percentage of kidney function you have been told you have, or carry the latest blood results with you. All of that will help to avoid certain potentially toxic, harmful exposure of the kidneys to the various medications or procedures. If we look at worldwide incidence of end-stage kidney disease, those who are on dialysis, you will see three major causes of end-stage kidney disease or dialysis requiring kidney disease. The number one is diabetic nephropathy in about 30% of cases. About 25% of patients, it is chronic glomerulonephritis, a form of inflammation, chronic inflammation of the filtering heads that we talked about, the glomeruli. And in about 10% of cases, it is a high blood pressure, uncontrolled hypertension that causes the kidney damage. So if you look at this, controlling blood pressure, diabetes, and controlling the proteinuria that causes the uh, protein loss in the urine. All of this is important in preventing somebody reaching end-stage kidney disease. Once the person reaches end-stage kidney disease, what are the options? Of course, we know dialysis, and dialysis is of two forms. One is peritoneal dialysis or chronic ambulatory or continuous ambulatory peritoneal dialysis, and the other one is hemodialysis. Dialysis is a process by which the impure blood is filtered and is cleansed of the various waste products, excess water, and all of that, and is returned to the person's bloodstream. In ambulatory peritoneal dialysis, the peritoneal membrane, which covers the inner surface of the abdomen, acts as the membrane across which the exchange takes place. So there is a 2-liter bag that the person can fill in using this dialysis catheter, peritoneal dialysis catheter, fill in the abdomen, and then carry on for 6 hours whilst the exchange takes place across the peritoneal membrane. And after 6 hours, drain it into a bag and fill in another new bag. And so this needs to be done 4 times a day. And this can be done when the person is working, studying, or whatever. Whereas if the person cannot do it during the daytime due to work commitment, due to studies, various other commitments, that can be done overnight with the assistance of a machine called an assisted peritoneal dialysis, APD. Assisted peritoneal dialysis overnight could be done, and the person can be free during the daytime. Doesn't involve much of a complicated machinery, can be done by the patient himself or herself, gives that independence and mobility. Whereas hemodialysis, usually performed in the hospital or in satellite dialysis centers, it can also be done at home but involves much more machinery, water supply, and few more things, but can be done at home as well, but most often done at hospitals or at satellite dialysis units. What happens here is the blood is taken out of the arteriovenous fistula, which is created specially for that purpose, and then passes through the hemodialysis machine, the center of which is a hemodialyzer filter, and then through the filter the waste products, the excess water, minerals, all of that is removed, and the blood is reconstituted, and then the blood is infused into the patient. So that is hemodialysis, and that requires to be done about 3 times a week, about 4.5 to 5 hours each time to achieve optimal clearances. When we say optimal clearance, they fall short of the kidney function that a normal kidney or normal pair of kidneys do perform, and therefore one has to realize that dialysis, though is life supporting, it falls short of providing the excellent quality of life and improvement in survival that a successful kidney transplant can provide. A kidney transplant is usually placed in the iliac fossa, either the right or the left, and the kidney could come from a live related donor or a friend, or could be from deceased donor. And if we see the survival amongst the dialysis patients, unfortunately, over the years, the survival keeps dropping, whereas although in the transplant patients also it drops compared to the normal population, the graph or this one is much less steeper. So better quality of life and better survival with a kidney transplant. So how to prevent the major killer diseases, not only chronic kidney disease, but heart disease, stroke, obstructive pulmonary disease, all of this, there are certain common denominators that we looked at, and now I have just tilted the pyramid upside down. So the basic factors to address are the physical inactivity, obesity, and smoking. Control the blood pressure, control diabetes well, and then use of ACE inhibitors or angiotensin receptor blockers, especially in those who have high blood pressure or proteinuria in patients with chronic kidney disease, and appropriate lifestyle with diet and glucose control. All of this, we can slow down the progression of chronic kidney disease, and we can win this battle against all these common chronic kidney disease and other common killers that are causing such a major disruption to the humankind. So it's very important that all of us, the public, the general public, the general practitioners, general physicians, specialists, doctors, amongst various specialties, join hands together to improve the quality of life, minimize the burden of these chronic kidney diseases in the community. Let's all work together, and let's spare a moment to be amazed by the amazing work that our kidneys do to keep us healthy and safe. Keep safe, take care. I'm Dr. Jagadish Chamboti. We'll meet again. Bye for now.